Today is September 6, 2022, and we are very sorry for the delayed start. We faced an unexpected technical snag. Sorry about that. So today, I'm Rifat Manna joining from California, and I am joined by my good friend Emilio Madrigal, who is in Boston. And we are very delighted to welcome Dr. Shefali Chopra today. She is Associate Professor of Clinical Pathology at Keck School of Medicine of University of Southern California. And today she's going to give a talk on liver pathology. And the title of her talk is Well-Differentiated Hepatocellular Lesions, an Approach to Pathologic Diagnosis. Thank you, Dr. Chopra, for joining us today. It's over to you now.
Thanks, Rifat, for the kind introduction. And today I'm going to be talking about well-differentiated hepatocellular lesions and an approach to diagnosis. And we'll talk about some ancillary techniques which would help us get to the diagnosis. So the well-differentiated hepatocellular lesions basically comprise of the following entities. There's focal nodular hyperplasia, then there are FNH-like lesions which are seen surrounding mass lesions, hepatocellular adenoma, dysplastic nodules, especially high-grade dysplastic nodules, well-differentiated hepatocellular carcinomas, and then there are some mimics which would mimic a hepatocellular lesion like a pecoma when they have eosinophilic cytoplasm, and the well-differentiated neuroendocrine tumor, especially the oncocytic variant, can also mimic a hepatocellular lesion on H&E. Starting with focal nodular hyperplasia, this is a non-neoplastic lesion. We see altered growth response as a result of localized vascular abnormality. So what do we see on the slide? We'll see a central scar with radiating fibrous septa, ductular reaction, and lack of interlobular bile ducts, and we'll have large dystrophic arteries within fibrous scars. So this is a needle core biopsy of a liver lesion. The lesion was 3 centimeters in size. Patient was 40-year-old female. And here you can see on low power you have these hepatocytes, and then you have this area of ductular reaction. You don't see any good portal tracts, native portal tracts or interlobular bile ducts in this biopsy, so you know you are in a lesion. And then on higher power, you would see that there is this ductular proliferation and these dystrophic arteries. And if you do a CK7 stain, this will highlight the ductular reaction. And the immunostain which we now use for diagnosis is a glutamine synthetase, which shows this very characteristic map-like positivity. And then we'll talk a little bit more about the stain and what map-like positivity actually is. So glutamine synthetase, normal liver is expressed in the central lobular areas around the central vein, and it is usually seen in only 1 to 2 plate of hepatocytes. So it's just perivenular staining when you are in a normal liver. What is a map-like pattern? What happens is large groups of hepatocytes, they express glutamine synthetase as broad anastomosing areas in hepatocytes enlarge adjacent to hepatic veins. And map-like pattern, though very helpful in diagnosis, sometimes it can get very tricky in needle cores, where you can either see focal staining, then you see strong staining of broad groups of hepatocytes, but you don't really see the characteristic anastomosing pattern. So the main differential diagnosis, like all hepatocellular adenomas are in the in the differentials, but then inflammatory hepatocellular adenoma mimics FNH more than other types. This adenoma would can have a central scar and prominent ductular reaction and thick-walled anomalous arteries. And they were formerly classified as telangiectatic FNH until they were found to be monoclonal lesions with clustering with hepatocellular adenomas on protein profiling. Hemorrhage and steatosis are more often seen with inflammatory adenomas but are uncommon in FNH, though steatosis can be seen in FNH also. So the glutamine synthetase staining pattern in adenomas is similar to normal liver, and then inflammatory adenomas can have patchy staining, and I'll show you an example in the next slide. And this can be misdiagnosed as map-like pattern, especially on needle core biopsies. Inflammatory adenomas also have strong cytoplasmic positivity for serum amyloid and or C-reactive protein. However, patchy serum amyloid or periseptal reactive protein can also be seen in a small percentage of FNH. So this is an example of an inflammatory adenoma, and you can see that the background liver is steatotic, and then you have these very dystrophic arteries, and this is the adenoma, no good portal vein, and this is a glutamine synthetase, and you can see that it has these patchy staining, especially on the periphery of the lesion, which can, if you were on a needle core biopsy, it can be mistaken for the map-like pattern of staining. This is another example. This is a 50-year-old lady who was on oral contraceptives, and you can see that there is this ductular reaction and prominent arteries. So histologically, it looks like FNH. So this was what I called it, but then you can see the map-like pattern is not perfect on this biopsy either. So what are the different patterns of glutamine synthetase staining? So the normal liver would have perivenular staining, which is, and adenomas also usually have perivenular staining, like the HNF adenomas. Then map-like pattern is seen in focal nodular hyperplasia. Then patchy staining, often with perivascular accentuation. This is non-specific pattern, and it's most often seen in hepatocellular adenomas without the beta-catenin accentuation, or with mutations of the exon 7 and 8 of the beta-catenin. So this type of pattern is the one which can be confused with an FNH. Diffuse staining. So diffuse staining can be of two types. It can be diffuse homogeneous staining. So this is either seen with activation of the beta-catenin exon 3, so the beta-catenin exon 3 mutated adenomas, and hepatocellular carcinoma. So there is diffuse homogeneous staining of the lesional cells. Like by diffuse staining, we mean greater than 90%. Then diffuse heterogeneous staining is like staining in greater than 50% of the cells, but less than 90% of the lesional cells. And this pattern of staining less strongly correlates with beta-catenin activation, but can be seen in certain exon 3 mutated beta-catenin adenomas, exon 8, 7, 8 mutations. So again, if you have this diffuse heterogeneous staining in an adenoma, you would probably need molecular profiling to get to diagnosis. Intermediate glutamine synthetase staining is moderate to strong glutamine synthetase staining in tumors in approximately 50% of the tumor cells, and this is indeterminate for beta-catenin activation. Talking briefly about FNH-like lesions, these can be seen in cirrhotic livers due to vascular alterations and adjacent to tumors or mass-like lesions. So if you have a mass-like lesion like a hemangioma, metastatic carcinoma, around those sometimes you can have this alteration of vascular supplies which would give a FNH-like lesion. So if you are not in the lesion, you can have a false diagnosis of an FNH. So what does it show? It shows numerous enlarged arteries in portal tracts with hyperplastic foci and slight ductular reactions, and then you can have sinusoidal dilatation. So radiologically, these show arterial phase enhancement, and so they can be radiologically confused with HCCs on imaging, though they never really show washout. So these are different from FNHs, especially in cirrhotic livers, because they do not show beta-catenin activation. So they have a different pathogenesis. So this is a 1.2 centimeter arterial enhancing lesion in segment 6 without evidence of washout in a patient with cirrhosis. And this is what the cirrhotic livers looks like, and you can see that this is the cirrhotic liver, and here you have this lesion which shows this central scars and some ductular proliferation. If you go on higher power, you'll see there is ductular proliferation and enlarged unpaired arteries. So this is an example of again showing the ductular proliferation. So this is an FNH-like lesion in a cirrhotic liver. Hepatocellular adenomas, these are clonal benign hepatocellular proliferation. So the main risk factor for hepatocellular adenomas is estrogen exposure in the form of oral contraception. So the other risk factors are fatty liver disease and obesity, androgen intake, vascular diseases, glycogen storage disorder, and sometimes familial HCA cases are linked with HNF1 germline mutations. Also, rare cases of inflammatory adenoma harboring activations in IL-6, ST, or STAT3 are reported in cirrhotic livers due to alcohol. Like cirrhotic livers due to alcohol and metabolic syndrome can have adenoma. Usually, differentiating like a mass lesion most likely in a cirrhotic liver would not be an adenoma, but like there are rare cases of an inflammatory adenoma arising in a cirrhotic liver. Pathologic features of adenoma is, so we know we are in a lesion because there is absence of portal tracts and then there are presence of isolated arteries. Pseudoportal tracts, by that we mean like bile ductular proliferation, can be seen in inflammatory adenomas. Very important to remember, before you start subtyping adenomas, you have to exclude a well-differentiated hepatocellular carcinomas, because the stains which are used for subtyping of adenomas have also been described in HCC, like LFA-BP loss can be seen in HCC, as can be SAA and CRP positivity. You can also have nuclear beta-catenin and diffuse glutamine synthetase positivity in both adenomas and HCCs. So it's very important before you start subtyping the lesions to exclude a well-differentiated hepatocellular carcinoma. So what is the main important distinction features between adenoma and a hepatocellular carcinoma? The most important feature is plate thickening, and that is highlighted by reticulin loss. So the reticulin is the most important stain, and reticulin interpretation can sometimes be tricky because when you have areas of steatosis, you can see loss in those areas. So when you're evaluating reticulin in a steatotic, well-differentiated lesion, try to look away from areas of steatosis. Sometimes regenerating benign liver can also have like mild patchy thickening, but it's not diffuse ever. And then rare examples of well-differentiated hepatocellular carcinoma have been described without reticulin loss. So other features you are looking for is at least mild cytologic atypia on the morphology. And then there are immunostains like glypican-3, glutamine synthetase, and HSP17 when used in conjunction can help you with diagnosis. So what are you looking for morphology in a well-differentiated lesion, which would kind of alert you to that this could be a well-differentiated hepatocellular carcinoma? So you see small cell change. By that we mean that there is higher NC ratio, ratio, and then also you can see pseudoacinar chain. Both these changes can also be seen in exon 3 mutated hepatocellular adenomas, and the other features you see is bile production, Mallory hyaline, again more often seen with hepatocellular carcinoma. So if seen, they are helpful. And stromal and vascular invasion are pathognomic of hepatocellular carcinoma, but then again, they are not always seen in needle core biopsies. So the immunostains which I mentioned briefly are glypican-3. So if positive is helpful, but a negative stain does not really exclude an HCC, as vast majority of well-differentiated HCCs, 70 to 80% of the well-differentiated HCCs are actually glypican-3 negative. So when you're interpreting the glypican-3, remember lipofusion may react with glypican-3 also. Glutamine synthetase is upregulated as a result of nuclear translocation of beta-catenin. So strong diffuse staining is seen with hepatocellular carcinomas due to abnormalities of the beta-catenin pathway, but can also be seen with the exon 3 mutated beta-catenin adenomas. The third stain is heat shock protein 70. Again, this is also seen more often with hepatocellular carcinomas than adenomas. It's not seen with adenomas. So Ki67 is important more, and it's more important when you have a background liver to compare with. It gets a little tricky to interpret the Ki67 when you do not have the background liver. So most hepatocellular adenomas and normal liver would show a proliferative index of less than 2%, whereas HCCs will have a proliferative index of equal to 5 or more. So not like a huge difference. And CD34 stain is not helpful in differentiating HCC from adenomas. Both can have diffuse sinusoidal staining. The only thing is that CD34 will tell you that you are in a lesion. So if you're having trouble telling whether you are in a lesional tissue or not, a CD34 stain can help you in that scenario. So what are the management implications of subtyping adenomas? So they are basically managed based on size and gender. So by that I mean that all adenomas in males are considered atypical. Adenomas greater than 5 centimeters are often taken to resection. So basically resection of adenomas greater than 5 centimeters and of all adenomas in male. Prognosis is driven by the molecular subtypes, and imaging and biopsy can help you subtype the adenoma. And some of the adenomas are unclassified by imaging and immunohistochemistry, of which a big percentage is the sonic hedgehog adenomas, and which have high risk of bleeding. Subtyping of adenomas is based on morphology, immunostains, and molecular alterations. So the 5 types of adenomas are the HNF1 alpha inactivated hepatocellular adenoma, the beta-catenin mutated adenoma, the exon 3 type, the exon 7-8 beta-catenin mutated adenoma, and inflammatory adenoma, and the sonic hedgehog adenoma. So the HNF1 alpha inactivated adenoma, the clinical features are they represent a vast majority of all the adenomas, and they have biallelic inactivating mutations of HNF1A. They occur with women with a history of oral contraception, as well as young patients of both sexes with maturity onset diabetes mellitus. The pathological features of HNF1 alpha adenoma, most of these adenomas have marked diffuse homogeneous steatosis without cytologic abnormalities, and they would normally not have extensive inflammatory infiltrates. There will be loss of expression of LFABP1, liver fatty acid binding protein 1 in the tumor hepatocytes. Malignant transformation in these types of adenomas is very, very rare, and when you see that, you will see pseudoglandular architecture, cytologic architectural atypia, and lack of steatosis, and more often seen in females and those with multiple lesions. This is an example of an HNF1 mutated adenoma, and here you can see that this is all lesional tissue, and here you can see there is background liver parenchyma. If you see here, there is no steatosis, and the lesion has fat, and then there are some inflammatory cells, not a whole lot, but then there are some inflammatory cells. So there is steatosis in the lesion and inflammatory cells. This is a higher power view of the same, and you can see steatosis in the lesional cells. And this is what the LFABP immunostain looks like. And here you can see the normal liver would have staining, and it is lost in the lesional cells. So this is a HNF1 alpha mutated adenoma. This is another example of a HNF1 alpha mutated adenoma, and here you can see there are these dystrophic arteries, and this is an adenoma. This one has less fat than the previous example, and you can again see that there is loss of the LFABP immunostain. The second type of adenomas we are going to talk about today are inflammatory adenomas. So these represent 40% of all adenomas, and they have uncontrolled activation of inflammatory pathway, which is the IL-6 STAT3 pathway. These are associated with oral contraceptive use, obesity, metabolic syndrome, and high alcohol consumption. So what are the features we see on histology on these adenomas? You'll see inflammatory infiltrates, dystrophic vessels, sinusoidal dilatation, and non-tumor steatosis. So the acute phase reactants serum amyloid A and CRP are C-reactive protein are overexpressed in the cytoplasm and these adenomas. Important to remember that FNH can also harbor focal positivity of SAA and CRP. So this is a 55-year-old lady with a 4.75 centimeter liver mass, and you can see that you are in the lesion because you don't really see any portal tracts. There are some dystrophic arteries present, and here you can see there are lots of inflammation. Higher power view of the same, a lot of inflammation seen, and reticulum shows preserved cell thickness, not a whole lot of thickened trabeculae, and the CRP protein is strong diffuse positive. So this is an inflammatory adenoma. This is another example of an inflammatory adenoma. Again, you see the dystrophic arteries and the inflammatory infiltrate. This case has little less inflammatory infiltrate as compared to the prior example. And here you can see again the dystrophic arteries, and this is a C-reactive protein diffuse positive, and this is a serum amyloid A. Serum amyloid A can sometimes be focal, so look at it carefully. So the third type of adenoma we are going to talk about is the beta-catenin mutated adenoma, the exon 3 beta-catenin mutated adenomas. So these are mostly seen in male and associated with androgen intake, and then 10 to 15% of the adenomas are exon 3 beta-catenin mutated adenomas. These do not have any specific radiological features as compared to the first two. So HNF1 alpha adenomas would, because of the steatosis in the lesion, would have steatosis which can be picked up on radiology also. And the inflammatory adenomas have sinusoidal dilatation which can be detected by radiology also. These do not have any characteristic imaging findings. The pathological features are cellular atypia, pseudoglandular formation, and cholestasis. So nuclear beta-catenin immunostain would be positive, and there is overexpression of glutamine synthetase, usually diffuse. Both these stains can be difficult to interpret on needle core biopsies, and sometimes they are less diffuse than the usual examples, and if they are less diffuse, then molecular analysis may be required for definitive diagnosis. So this is like a classic case, and here you can see that there is this higher NC ratio, there is pseudoglandular formation right here, another pseudogland right here. And then this is diffuse glutamine synthetase and nuclear beta-catenin positivity. So this is what an exon 3 beta-catenin mutated adenoma would look like. Sometimes not all examples are this classic, and then if they are less than, they can sometimes have very focal beta-catenin and patchy glutamine synthetase, and then that's when you would need molecular profiling to help you in diagnosis. Then the exon 7, 8 beta-catenin mutated adenomas, they make up approximately 10% of the hepatocellular adenomas, and they have mutations of the CTNNB1 gene located on exon 7 on 8. And these are characterized by mild activation of the WNT beta-catenin pathway. So these do not have that high risk of malignant transformation. The beta-catenin exon 3 adenomas are associated with higher risk of malignant transformation, and these are not. And half of these beta-catenin exon 7, 8 adenomas have an inflammatory phenotype. So approximately half of them would have the inflammatory phenotype, and then they would have the sinusoidal dilatation and stuff and inflammation, which you would see with the inflammatory phenotype. So this is an example of exon 7, 8 beta-catenin mutated adenoma, and here you can see that this one would have the sinusoidal dilatation, the inflammatory infiltrate, and the CRP protein is strong diffuse positive, but also the glutamine synthetase and the beta-catenin are also positive. So this would be an exon 7, 8 mutated adenoma, and it is also has the inflammatory phenotype. So not all cases are that classic, and here you can see that there is this adenoma. This one has fat, and this is the normal liver. So looking at it, you would think that this would be a HNF mutated adenoma. However, there was no loss of LFA-BP protein in this adenoma, but it did have very focal nuclear beta-catenin positivity. So this is a case you would need molecular profiling to tell you whether this is an exon 7, 8, which is more likely, or it's an exon 3 mutation. The sonic hedgehog mutated adenomas. So these are 4% of all adenomas, and this is the most recent subtype described first in 2017. And this is activation of the sonic hedgehog pathway due to fusion of promoter INHBE with the GLI1 gene, which leads to overexpression of GLI1. So these are often occur in women who are obese and associated with symptomatic bleeding. So these are the ones so besides the exon 3 beta-catenin mutated, which have increased risk of malignant transformation, it is kind of important to try to identify these subtypes because this would have associated symptomatic bleeding. So pathologic features, so they would have histological hemorrhage, and usually the surrounding liver is steatotic because they are associated with obesity. So the two stains which are used for diagnosis are the prostaglandin D2 synthetase and the arginosuccinate synthetase 1. So the prostaglandin D2 synthetase is specific, but it has poor sensitivity, so it will not pick up all the cases, and the ASS1, while being sensitive, is not specific. So both of these immunostains are not easily commercially available, so it kind of is difficult to diagnose this subtype. If you do see histological hemorrhage and don't have access to the stain, you can just raise the possibility that these might represent a sonic hedgehog adenoma. So these adenomas also show decreased LFA-BP staining. However, there is no complete loss as compared to the HNF1 mutated adenomas, which have complete loss of staining. These would not have complete loss, so there will be some decreased staining, like patchy loss and less intensity than the background liver. So this is directly from the paper. Because I did not have a good example of the immunostain, and here you can see that it can happen in both, like this is the non-tumor liver, and you can see the background is steatotic as opposed to non-steatotic, and because of the ischemia, the cells are kind of all, they have hypereosinophilic and they are kind of packed, and there are areas which would have this blood cavities at different stages, which is what we mean by histological evidence of hemorrhage. So you'll see that there are these blood-filled cavities and hemorrhage, and here you can see that you have again this hemorrhage surrounding this vessel, and sometimes when the hemorrhage is long-standing, you can have fibrous band development. And this is an example of the ASS1 immunostain on this paper, from this paper only. And here you can see the non-tumor liver would have this honeycomb pattern of staining. The tumor itself can be diffuse, like almost all the cells are positive, or it can be heterogeneous, as seen in this and this, both these examples. Like you can have heterogeneous staining of the ASS1 stain. So briefly summarizing the different subtypes of adenomas. So the HNF1 alpha inactivated adenomas, they would have the HNF1A mutations associated with mature onset diabetes, and the risk factors are the germline and the OCPs. The clinical presentation is female, usually multiple adenomas. Histology, most tumors show steatosis, and there would be associated adenomatosis, so you would likely have a microadenoma. There will be less hemorrhage, and the LFABP immunostain would be negative. So the exon 7, 8 beta-catenin mutated, they have weak beta-catenin activation, and they happen in young patients. So they will have, because they are beta-catenin activated, they would have some cytologic atypia, but they are not at increased risk of malignant formation. And these would have faint glutamine synthetase staining. Then the inflammatory adenomas, they have activation of the IL-6, STAT3 pathways, and they are associated with obesity, oral contraceptive use, also seen with alcohol and metabolic syndromes. And these are the subtypes which have been rare examples have been described in cirrhotic livers. Then clinical presentation, usually older patients, asymptomatic, and they might have a accompanying inflammatory syndrome. So the histology, you will see an inflammatory infiltrate. You would have sinusoidal dilatation. You will have dystrophic arteries and non-tumor steatosis. The SA and or the CRP would be positive. The exon 3 mutated beta-catenin adenomas usually associated with androgen use, and they are seen in younger male patients and have a higher risk for malignant transformation. So they usually have cytologic atypia, cholestasis, and they can be greater than 5 centimeter in size. So the glutamine synthetase would have diffuse positivity, and you would, if you look carefully, have nuclear beta-catenin positivity also. The sonic hedgehog activated adenomas, they are due to INH, BHE, GLI1 fusions. They are associated with obesity and oral contraceptives. They are associated with both symptomatic and histologic bleeding. And then because they are associated with obesity, they will have non-tumor steatosis, like the surrounding tumor would be steatotic. The prostaglandin would be positive, again very specific but not very sensitive to pick up all of the adenomas, and the ASS1 would be positive. So the ASS1 is more sensitive but not very specific. So moving on, atypical hepatocellular neoplasms or humps, hepatocellular neoplasms of uncertain malignant potential. When you have a well-differentiated hepatocellular lesion which is architecturally or cytologically atypical, and you cannot make a clear-cut distinction between a hepatocellular carcinoma and an adenoma, especially on needle core biopsy, you can call them atypical hepatocellular neoplasm / or a hump, and so these cases would go to resection even if the tumor size is less than 5 centimeter. We discussed earlier tumors which go straight to resection are tumors in males and or size greater than 5 centimeters. But even if these tumors are less than 5 centimeters, they would go for resection. So there are clinical and histological criteria for calling a tumor atypical. All tumors in men, all hepatocellular adenomas in men should be treated as atypical, and women greater than 50 years. The histological criteria which you see are small cell change, pseudo-actin architecture, and thick cell plates involving less than 5% of the tumor. So let's talk a little bit about the well-differentiated hepatocellular lesions you would see in a background of cirrhosis. So the two most important ones are high-grade dysplastic nodules and well-differentiated hepatocellular carcinomas. Kind of important to differentiate the two if you can, because if you have small HCCs, they can be treated by surgery or ablation, and also they will get extra melt points, so they will help the patients get appropriately prioritized for liver transplantation. So the small HCCs and cirrhotic nodules are often hypovascular and do not show the typical imaging findings, and those are the ones which get biopsied. The differentiation of high-grade dysplastic nodule from an early HCC can be very difficult on a needle core biopsy. And the most important feature which on histology would be either you see stromal invasion and or vascular invasion. So what are the histological features of high-grade dysplastic nodules? You'll see cytologic atypia and or architectural atypia. By cytologic atypia, we mean small cell change, which would mean like higher NC ratio, unpaired arteries, focally thickened plates, and or focal reticulum loss, and all these features would overlap with HCC, but these would not demonstrate stromal invasion. Sometimes on needle core biopsies, you do not have the edge of the nodule to evaluate for stromal invasion. Features that favor HCC are thick cell plates, more than focal, prominent pseudogland formation, and loss of reticulum framework. Vascular space invasion, diagnostic of HCC as a stromal invasion, but this is sometimes difficult to see in early lesions or on biopsies. Glypican may not be very useful because most of the well-differentiated HCCs, 75 to 80% of them would be glypican negative, and sometimes the high-grade dysplastic nodules would also have glypican 3 positivity. Stromal invasion and is something you look for, and this is you see the neoplastic hepatocytes into the perinodular portal tracts, fibrous septa, or you see them invading into the adjacent liver parenchyma. So CD34 is more often seen at the periphery of the high-grade dysplastic nodule. It won't be that diffuse as compared to an HCC, and heat shock protein often seen in early HCCs, but less often seen in high-grade dysplastic nodules. Glutamine synthetase may not be helpful because it can be positive in both, though it is usually not as diffuse in a dysplastic nodule as it is in HCC. So the recommendation is to use all three of the stains, and if two of the three stains are positive, most likely it's an HCC. So the three stains to use would be Heek short protein 70, the glypican 3, and the glutamine synthetase. And then if you have two of these three markers positive, then they have a sensitivity of 60% and 100% specificity. So this is a 2.2 centimeter mass in a cirrhotic liver, and here you can see that this is the background liver for comparison. You can see that there is higher NC ratio, there is pseudogland formation. Again, higher NC ratio, you can appreciate the pseudogland formation. And the reticulum doesn't shows patchy loss. It's like they are kind of thickened, but very focally. Some are not. And the other three stains, the heat shock protein was negative, the glutamine wasn't diffuse positive in this case, and the GPC3 was negative. So this one, like you can call a high-grade dysplastic nodule, or at least high-grade dysplastic nodule. This is a 2.5 centimeter mass in a patient with hepatitis B virus. This patient did not have cirrhosis. Again, you can see there is higher NC ratio, some attempt at pseudogland formation. So the architecture is architecturally it's off, and then there is high NC ratio. And this is a reticulum stain. The reticulum stain shows, like here you can see that there is like diffuse loss of reticulin, like it's not just focal, like almost every plate is thickened. And this is a heat shock protein, and this is positive, as was the glutamine synthetase, which was diffusely positive. So this is a well-differentiated hepatocellular carcinoma. So this is a steatotic lesion, and in a cirrhotic liver, these can be harder to interpret because you don't see the higher NC ratio very well. And but if you come to the area, so the key is to look away from the steatotic areas, and here you can see some attempt at gland formation, like the pseudoglandular formation. So there is some attempt at pseudoglandular formation, and you know that you are in a lesion because you do not see any portal tracts. Again, a higher power view of the lesion, you can see that there is some atypia, but again, it's really hard to appreciate the atypia because of that much steatosis. The reticulum stain does show some loss, but it's not like perfect, and then steatosis is not the area to appreciate the reticulum loss. Again, this is the glutamine synthetase. In this case, it was diffuse positive, and then the GPC3 also had patchy positivity. So this is a well-differentiated hepatocellular carcinoma, and the Ki67 looks like closer to 5% than 2%. Though it is harder to interpret in this case because there was no background liver, non-tumor liver to compare it with. So this is another example of the Ki67, like when it is actually useful. So here you can see that there is this sharp demarcation right here. You can see that this is the background liver, and this is the lesional tissue, and which has higher NC ratio, attempt at pseudoglandular formation, and this is the Ki67, and you can see that the Ki67, if you compare, like this is the area of demarcation, it is definitely higher in the tumor than the background liver. Another example of a steatotic well-differentiated HCC, you can see that it's got a lot of steatosis. The glutamine synthetase diffuse positive and the glupican-3 diffuse positive. So this is a well-differentiated HCC. This is another example of a well-differentiated hepatocellular neoplasm, and you can see it's arising in a cirrhotic liver, like not it's kind of out of the field, but here is one nodule, that's another nodule, and this is the lesion. And if you compare the lesion with the background liver, you can see that there is higher NC ratio. This is the Ki67, which you can see is like definitely increased if you compare with the background liver. And here you can see that this is the septal band, and you can see that there are some infiltrating tumor cells. So this is stromal invasion, and this is a higher power view of the stromal invasion. The tumor cells are infiltrating into the septal band. Here again you have this septal band / portal area, and you can see that there are infiltrating tumor cells. So this is stromal invasion, if seen, is definitely helpful in the diagnosis of a hepatocellular carcinoma. Then this is a 35-year-old man who was being evaluated for cardiac transplant and was incidentally found to have a 2.5 centimeter liver mass. If you look at lower power, you see this lesion. It's got like eosinophilic cytoplasm, and if you look at it briefly, you would think that these are hepatocytes. And again, higher power view of the same lesion. Again, you'll see that they have a lot of eosinophilic cytoplasm, no portal tracts. So if you're not thinking well enough, so this is one of the mimics, and you can see again, like it does have appearance with the eosinophilic cytoplasm. It does have the appearance of a well-differentiated hepatocellular lesion on histology. And then if you just do the retic, these tumors would also see retic loss. You can see the plates are thickened, there is loss of retic. But this is not actually a hepatocellular lesion. It is actually a pecoma, and the HMB45 and the melan A were both strong diffuse positive in this case. So this is the final slide which I'm going to be sharing, and which way we'll go down like this pathway, like if you have a lesion, how do you approach it? So if you know you are in a lesion because you have no portal tracts or you have pseudo portal tracts, and then the CD34 shows diffuse sinusoidal staining. So that is how you would be sure you are in a lesion as opposed to just liver parenchyma. And once you are sure you are in a lesion, then the three differentials you would have is hepatic adenoma, well-differentiated hepatocellular carcinoma, or focal nodular hyperplasia. So the most important stain is the reticulum stain. If you have a well-differentiated liver lesion and you have loss of reticulin, it is a hepatocellular carcinoma, especially like the caveats we've just discussed. If it's steatotic, you just don't rely on the retic stain, you do ancillary stains. So a lot with the loss of reticulin stain, it would be a hepatocellular carcinoma. Other ancillary tests, other ancillary stains you can do is like a glypican 3 positive helps, negative does not exclude, a diffuse glutamine synthetase, and or HS heat shock protein 70 positivity. The second scenario is you have a preserved reticulin. So in this scenario, when you have a preserved reticulin, then the differential would include an adenoma versus an FNH versus rarely HCCs. So if you have a preserved reticulin and normal glutamine synthetase, by normal we mean that it is either just perivenular or it is patchy, not strong diffuse, then most likely you're dealing with an adenoma. So once you're sure you're dealing with an adenoma, then these are the stains you would do to try to subclassify them. So if the adenoma has loss of LFABP, then it's an HNF1 alpha mutated adenoma. If it has SAA and or serum C-reactive protein positivity, then it's an inflammatory adenoma. These are mostly associated, the HNF1 alpha mutated adenomas are associated with steatosis. Inflammatory adenomas are associated with inflammation. And then if you have ASS1 or PGS positive, then it's a sonic hedgehog pathway mutated adenoma. And these are usually have histological evidence of histological and symptomatic bleeding. So this is when you have tumor with preserved reticulin and normal glutamine synthetase. If your glutamine synthetase is diffuse and strong, so then you're either dealing with a beta-catenin activated adenoma versus an HCC. So because the retic is preserved in this scenario, so most likely it would be a beta-catenin activated adenoma, but you can always do the glypican 3 and or heat shock protein 70 to make sure you're not dealing with a well-differentiated hepatocellular carcinoma with preserved reticulin. That's a very rare scenario. And then the third scenario would be glutamine synthetase has a map-like pattern of staining. So then that is an FNH. If the tumor shows focal loss of reticulin, then you call it a atypical hepatocellular neoplasm or a hepatocellular neoplasm of uncertain malignant potential. Again, you'll do the three stains, so the glypican 3, the glutamine synthetase, and HSP70. Two of the three are positive, then it's most likely a hepatocellular carcinoma. If you see stromal invasion and or vascular invasion, then you're dealing with a hepatocellular carcinoma. And then NGS can be useful. So the more common seen alterations in well-differentiated hepatocellular carcinomas would be like a third promoter mutations, P53. So these are not usually used for diagnosis, but like there is emerging evidence and they might be used for diagnosis at a later date. So that would be all for today, and please let me know if you have any questions.
Thank you so much, Dr. Chopra. So this was an excellent talk on the well-differentiated hepatocellular lesions, and especially this is a problem that as pathologists we face very often in our practice, and more so when we are dealing with a biopsy and we need to differentiate between these three entities, and we don't have much of support from radiology sometimes. So let me see if what are the questions that I see online. One second. So there is one question from one of our viewers who wants to know, like, what is your experience with HSP70 as far as diagnosing these lesions are concerned? How often do you use it? Because not many labs have that immunostaining.
Yeah, so if I have a tumor which is both, which has reticulin loss and diffuse glutamine synthetase and or GPC, I would usually not go for the HSP70. Because like you said, it's very difficult to get the immunostain. We don't have it in-house, and it's usually a send-out. Mayo Clinic does it, and I think UCSF does it. The other problem with the stain is like it's kind of difficult to interpret also, like what is positive. So the cases I've had, they're not usually diffuse positive, but any staining greater than 5 to 10% is considered positive. So those are the two things. But yeah, I don't use it very often. But like if you're caught, like if you have preserved reticulin and then you're thinking it is most likely like you're having trouble differentiating it, like from a high grade dysplastic lesion, and then it would push the patient in and out of the Milan criteria for transplant, and that those are the few scenarios where I would like to get the stain just to see if it would help me.
Right, right. No, thank you. And looking at your last flow chart, I think that is very helpful, and one appreciates that probably the most important but often undervalued stain, or the, like, ancillary aid, is the reticulin stain for differential diagnosis of well differentiated hepatocellular lesions, isn't it?
Yes, the reticulin is the single most important stain.
Right. And then, like, I mean, as you rightly said, that the Glypican tree can go either way, isn't it? Like, I mean, and we have seen in our practice too that if it is well differentiated, so Glypican tree can be negative, and it does not help in our diagnosis when we have
Yeah,
biopsy.
yeah, the few times you actually want it to be useful, it is like it's mostly negative, like a good 75-80% of the well differentiated hepatocellular carcinomas are glypican 3 negative as per literature, but I don't know, in my experience it's probably even more. It's like glutamine synthetase is a little more useful than the glypican 3 because it will show the diffuse staining.
Right. No, I totally agree with your view on Glypican tree, because once, I mean, if you are relying on Glypican tree, most of the time, practically what happens is that you have already proven it otherwise, that it is a hepatocellular carcinoma, and you are not relying on Glypican tree at all, right? And
Yes.
another question about Glypican would be about what is your experience about Glypican in poorly differentiated carcinomas. I know this talk is on well differentiated lesions, and in our practice, often we find that even in poorly differentiated the lesions, also that Glypican is not very helpful, right?
Yeah, so the poorly differentiated tumors, the immunoprofile, like the immunostains you would be doing would be a little different. The stains you'll be doing a HAPAR, arginase, a CK7, those are the stains you'll be trying to do once you've established that you're definitely dealing with a liver primary. So you're trying to separate like I'm just saying, like in case you're sure and you have an RNA albumin-ish positive tumor and you're still not sure whether it is a hepatocellular, like very poorly, or it's a very poorly differentiated cholangio. So I don't know, Glypican 3 sometimes is more often positive than the Hepar and arginase, though it's not again 100%. And sometimes I found, like in my molecular profiling does help in those cases, like the HCCs would have the TERT promoter mutations, and then the cholangios would have the IDH1 and the BRAF and the other ones. Yeah, but like again, Glypican 3, yeah, it's probably a little more positive than the Hepar and the arginase because like the really poorly differentiated hepatocellular carcinomas sometimes lose the Hepar and the arginase before they lose the Glypican 3.
True, right. Thank you. And what about your experience on glutamine synthetase? And you have explained quite a lot about the utility of glutamine synthetase. I think this is probably one stain which is more easily available as compared to some other stains in the labs, right? And on biopsies, so sometimes in practice, as you have mentioned, that map-like staining can be very difficult to appreciate. And I mean, if it is a resection, then it is fine, but I mean, if it is a biopsy, I mean, one has to be really lucky to actually appreciate map-like staining, and then differentiation between an adenoma and FNH can be very difficult. What is your experience on that?
Yeah, so the inflammatory adenomas versus the FNH can be really hard on biopsies, and uh, so you do the best you can, but at the end of the day, like the glutamine synthetase can be patchy. You look for histological criteria, like more often than not, that FNH would have the central radiating scar or some semblance of it, though you can see unpaired arteries in an adenoma also, but you do the best you can, and you can, if you're not absolutely sure, I think it's perfectly fine to just favor one over the other. At the end of the day, both of these entities are benign, and I don't think the clinicians really care that much.
Right, thank you. And so here's another viewer who wants to know, suppose you have a biopsy and the biopsy shows a well-differentiated lesion, and the radiologist says that it's a single lesion, and one is not sure at the end of all the markers that could be done. So then what is your advice on reporting such a case that you're still unsure, but how would you sign it out?
So the couple things you want to be sure of before you are signing it out is like, uh, you kind of try to at least classify it as benign, atypical, or hepatocellular carcinoma. And if it has one of the atypical features, it's best to call it atypical and put it in that category so that it can go for resection, as opposed to trying to just call it benign. So those are the three categories you should try to put the tumor in, at least, because that would probably have therapeutic implications. You said it's a single lesion, and so the single lesions, either they follow or they excise, and then if you if you're sure it's benign, and whether you can classify it as an adenoma versus an FNH, and as the clinicians won't care unless it's the beta catenin mutated adenoma, because most adenomas do not have high risk of malignant transformation. So the things which go often for resection are like size greater than 5 centimeters, male sex, androgen intake. So those are few things which the clinicians would like to do. And then if you're not sure, and if the histology is atypical, those are the ones which would go for resection. At least try to put them in those three broad categories. That would be helpful from the clinical point of view.
Thank you. And one very important point that you have mentioned is when the patient is male. So if it is a male patient and the radiology still sometimes that suggests that, oh, this is a single lesion, adenoma on radiology is likely, then what is your approach in a male patient with such a lesion on biopsy?
So the thing is, like, if you're sure it's an adenoma, then sure, you call it one. But if you're not, then just like call it atypical. I don't know. Most male adenomas go to resection regardless of what you call it. That's another thing, because there are very set clinical parameters for management of adenomas. And the ones which are classified as atypical based on clinical features, the two important things are greater than 5 centimeters and male. So if it is a male patient greater than, like, if it's tiny, patient doesn't want surgery, then they might follow it. But like, the other thing is, if you're in a male patient, then make sure you're not dealing with an exon 3 beta catenin mutated adenomas, because again, those will have risk for malignant transformation. So those are, most often than not, your clinicians will take a adenoma in a male for resection.
Right, and actually, this is relevant. We had a recent case in our institution. The patient is male and was, after multiple consultations at different institutions by expert liver pathologists, the diagnosis on biopsy was hepatocellular adenoma. The patient is young, I think in his 40s, and they did a radio ablation. And after 4 years or so, now there is a recurrence. And the histology is very similar to what was before, and alpha fetoprotein is still, I mean, it is still normal. So I mean, and they did not resect it. So this time, like I mean, so it was discussed in a tumor board, and they were debating still like how to move forward with this patient's management.
So did they try to subclassify that adenoma at that point when you said it
No,
went to multiple?
I think they
Yeah, so
saw
that,
that likely inflammatory, and
yeah,
beta catenin was focally nuclear, but it
yeah,
was very very focal. And I
yeah.
reviewed the
So
slides; it was very focal.
yeah, so those can get very tricky. The focal beta catenin, like maybe they should go for molecular profiling. I don't know. Most of us are not doing molecular profiling on diagnosis of well differentiated hepatocellular lesions, at least now. But like maybe in the future, it would be a part of the diagnostic algorithm. I think. I don't know. Like we are not doing it at our place, but our clinicians are very skeptical of male adenomas. They take them to resection.
Right, right. I think that is a good approach because even at that time, a resection was suggested in the report, which was 4 years back, but they ended up doing a radio ablation instead.
Yeah.
Oh, thank you.
Yeah,
And
because the focal beta-catenin can be very difficult. Like most likely, like you said, it might be like the inflammatory subtype with the exon 7, 8, but then it's a male patient and you're not sure. It's always best to resect.
right, thank you. And there is another question from one of our observers is, what is your experience about hump? I mean, is it a real entity, and what is your criteria?
It's so it's like not a real entity, but like there are times like in spite of doing like we just discussed, like in spite of doing your best, especially on needle core biopsies, you cannot tell. And I mean, there's only so much you can do. So it's not a real entity. We all agree it's more like a wastebasket when you're not when the pathologist is not sure.
Right, right. Because I mean, in hump, so one that means that we are upgrading it to a possibility of a well-differentiated HCC as well, isn't it?
Yeah, yeah, that's what I'm saying. But like there are cases sometimes when you've done all the stains and then you're like, I'm really not sure.
Right,
And then I think that's very fair to take these cases to resection. Most often than not on resection you can't tell because sometimes the reticulum is like focal loss and you're not sure how far you want to go with it. You don't want to overcall an hepatocellular carcinoma either, but the reticulum loss is bothering you. So it's always best. Like if it's a solitary lesion and easily resectable, I don't think there is any reason not to resect it. Things
right.
which could help in the future is like third promoter mutations. I think there are a few studies where they have shown that like the third promoter can actually be useful in these scenarios. But like I don't know, we are not doing it real time. I don't know if you are at your institution.
No, 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 I don't know. We are not doing it either.
Yeah, because it's like easily resectable. That's the thing, right? Like if you have a solitary liver mass with no, like resection of liver masses in cirrhotic patients can be a problem because you're losing the liver parenchyma or whatever. But like if you have a normal, otherwise healthy person and you have a liver mass, like there is no reason not to be able to resect it, right? It will, liver regenerates also. So it's not going to land the patient into decompensation or something. So
Right. So one question that has come up from one viewer is that how much do you rely on clinical information, radiology, and serum alpha fetoprotein?
the serum alpha fetoprotein is not very useful. Like I don't know if it's positive, it's good. Like it helps you. Like you're thinking hepatocellular carcinoma, the serum alpha protein is high. You're like, oh great, this is good. It's all matching up. But like you can't rely on serum alpha protein. That's number one. The next question is clinical criteria for hepatos. So the question was for hepatocellular carcinomas.
Yeah, in general, like I mean, when you
Yeah, so the
diagnose,
thing
yeah.
is like, if it's a woman on oral contraceptives, then you're thinking hepatocellular adenoma even before the biopsy comes to you, right?
Hmm.
Like, yeah, like the clinical scenario helps, the radiology helps. Radiology is like advanced quite a bit in the last couple of years. They can subtype adenomas also, but again it depends on how good your radiologists are and how much you trust them.
True, true.
Like radiology is very useful, but then I don't know, sometimes some radiologists are better than others. Uh, I've seen that with my personal experience also. And then like not every place has that kind of radiological input. Like our place does because we are a big transplant center, but like most other places don't have that like very refined radiology. Neither do they have the like the MRIs with and without EVIST and all. Like yeah, so if you have it, it helps, but like if you don't, then you're where you started.
Right, right. No, no, thank you. These are very useful information, and it's very practical. And just to highlight what you have said, that it's ultimately it boils down to the morphology and a good interpretation of a uh, well done reticulum stain, because like reticulum stain sometimes is not done properly in all the labs, so that can that can create trouble. And other stains, as you said, that they are useful, but depends on availability and interpretation and things like that. Thank you very much, Dr. Chopra. I think these are the questions that I found online, and you would be happy to hear that we had viewers from so many different countries. Like I could see that our viewers joined from Yemen, Mexico, Kenya, India, Uzbekistan, and Bolivia. At least these names that I could see, and someone said just hello from Germany. So thanks to our viewers for joining, and we appreciate your support. And if you like our lectures, don't forget to subscribe to our YouTube channel, where you can find all the lectures. So far, there are more than 200 lectures on different subspecialties of pathology. And you can also follow our Facebook page, that is Pathcast, where I mean you will be updated about the upcoming lectures. And we have a website, that is thepathologicast.com, where you can access all the lectures as well. So our next topic is on September 20th, and we will be having a discussion on GI pathology, and the topic is inflammatory bowel disease related dysplasia, which is again another very important topic for practicing pathologists everywhere. And our speaker will be Dr. Deepti Dhal, who is well known for her expertise in GI pathology, and she's a professor at the University of Alabama at Birmingham. So hope to see you then. And once again, the time is 9 p.m. Pacific time, 9 a.m. Pacific time, sorry, and 12 p.m. Eastern time on September 20th. And thank you all, and thank you, Dr. Chopra, for joining us today.
Thank you, Rifat.
Thanks so much.
Thank you.